Medurstand Understanding Medicine.
I am Professor Aziz-ur-Rehman, and we are discussing various types of anemias. And today we're going to take up this iron deficiency anemia, which is undoubtedly the commonest type. So common that if you confront a case of anemia, iron deficiency would be the diagnosis by default. Once diagnosed, then you will have to determine the cause of iron deficiency. And without that, I think the diagnosis is not complete. Of course, you will have to consider other causes of anemia. So in this lecture, we have discussed basic approach, how to find out which way to investigate. But after we have discovered the patient has got hypochromic microcytic anemia, we will investigate further the iron deficiency type. I think before we discuss iron deficiency anemia, let's discuss some basic facts about iron metabolism. Iron is absolutely essential nutrient, and it is absorbed from the gut. And various nutrients, they are absorbed in different ways, and most of the nutrients, they are absorbed. The total amount what we ingest is absorbed, and then their level is regulated by metabolism, by the liver, and also by the excretion. But iron is regulated at the level of absorption. That means if your body is deficient in iron, more will be absorbed, and if your body is adequate in iron, if your iron stores are adequate, then less will be absorbed. On the average, 1 milligram per day is absorbed, and iron is mostly present in red meat in the form of heme. It is also present in vegetables and fruits and other foods in very small quantities, but that iron is actually not easily absorbable. Best iron in the food is in the form of heme. So 1 milligram per day is absorbed, and almost the same amount is excreted through shedding of cells. There is, to my knowledge, there is no renal excretion of iron. So iron, once absorbed, is brought to the liver for further storage, and also some is taken to the bone marrow for hemopoiesis, because main need of iron in the body is for hemoglobin synthesis. It is of course also needed for myoglobins and cytochrome system. Liver stores some iron in the form of ferritin and other proteins, but most of the iron is consumed by the bone marrow. So this is the mechanism. If your absorption mechanism is abnormal, like in hemochromatosis, this control mechanism is abnormal, then too much iron may be absorbed, and that may result in excess of iron. In some condition, when there is gastritis and some gut surgery and less may be absorbed, that may also result in iron deficiency. So this is very, very basic knowledge about iron metabolism. Differential diagnosis of hypochromic microcytic anemia, very likely that if you have a case of hypochromic microcytic anemia, it will turn out to be a case of iron deficiency, but there are other causes also. So I think depending upon history, I always say if the cause of iron deficiency is obvious on history. For example, patient is suffering from malnutrition, patient is not taking enough meat, patient is undernourished, patient has some kind of malabsorption, and then the cause may be obvious. But otherwise you will go for the investigation, and various iron tests are available. I think in doubtful cases it is always good to go for the test and be sure before we start treating. So if the iron is low, then it would suggest iron deficiency anemia, and then we should start treating with iron. Of course, we will have to find the underlying cause also. Mostly, if it is external loss, it will be obvious in the history. But if the blood loss is occult from the stomach or from the intestine, largely from the large colon, then it would be lost, as the blood will be lost. It will not be visible, it will be occult blood loss. I think we need to have further tests like stool test for iron, maybe upper GI endoscopy, lower GI endoscopy, abdominal CTs. These kind of tests will be needed if the picture is hypochromic microcytic and there is no obvious cause of iron deficiency in history. Then in these patients with the hypochromic microcytic picture, many other tests will be needed, and this arm we will discuss in thalassemia. So some basic facts about iron deficiency anemia. It is very common. In my opinion, it is the diagnosis by default, and chronic blood loss is the commonest cause, although malnutrition may be the cause. When we have chronic blood loss, for example, there is peptic ulcer, there is loss of blood, or there is menorrhagia, there is loss of blood, and everything else which is required for hemopoiesis, that gets replaced because we have abundant vitamins in the food. The limiting factor is iron. So everything else gets replaced. If iron is not supplemented, then there will be overall deficiency of iron, and the picture of anemia will be that of iron deficiency. So it is due to chronic blood loss or malnutrition or both combined. Then it is also important to know that you need to have total body iron depletion to develop anemia, because we have some stores in the liver, in the bone marrow, elsewhere. Only when total body iron is depleted, only then we develop iron deficiency anemia, because body mobilizes whatever iron stores to produce hemoglobin, and only when total body iron is depleted of iron, only then we develop iron deficiency anemia. And there are various tests to confirm iron deficiency anemia. Of course, the picture would be hypochromic microcytic. Serum iron is one test, but I think all these tests, they have some problem. Let me just briefly discuss the issues with them. Serum iron, for example, because if somebody has developed iron deficiency anemia, but that patient has started taking iron, the serum iron level may be already normalized, but the patient would still have iron deficiency anemia because it would take several weeks to months before actually anemia will be corrected. So you need to ask the patient if the patient has already started taking iron. If the iron turns out to be normal in a person where you actually suspected iron deficiency anemia. Total iron binding capacity, this is actually the protein, I think transferrin, which is produced by the liver. Once there is iron deficiency, body makes more and more transferrin, just an attempt to bind more iron, but the iron binding capacity is actually increased. And that would be affected if patient has extremely advanced malnutrition, protein malnutrition. So despite iron deficiency, total iron binding capacity might not increase, and this will also be present in chronic inflammatory states. Serum ferritin is generally considered to be the best test. Serum ferritin is also, there are some caveats in serum ferritin also. Ferritin is actually a protein which is synthesized by the liver, and it reflects total body iron stores. It does not reflect serum iron, it reflects the total body iron store. Low ferritin would mean that total body iron is depleted, and normal ferritin mean that the total body ferritin is adequate. Number one problem with ferritin is that if you look at the normal range, it is quite wide. So if any test is wide range, it is difficult to interpret a certain value. Number two is that ferritin is acute phase reactant. That means in any acute stressful condition like some infection, ferritin would be elevated. So it is possible that patient actually had iron deficiency anemia, but ferritin is normalized because it is elevated due to acute stressful condition. Patient with anemia may be going through a stressful condition, some acute infection. So despite the fact that that individual actually has iron deficiency anemia, ferritin level may be normal. So that is the problem with the ferritin. So sometimes we end up having all three tests to get the clear picture. Bone marrow is normally not done for the diagnosis of iron deficiency anemia, but to complete the concept of iron deficiency, iron is basically stored in the bone marrow, and I have already told you that you need to have complete depletion of iron before iron deficiency anemia develops. So in the bone marrow, if we stain it for iron, there will be complete absence of stainable iron in the bone marrow. So that is generally considered to be the final and 100% reliable test for iron deficiency anemia, but mostly we do not have to go that far. Mostly the diagnosis is obvious on history, and one or two of these tests will confirm the diagnosis, and we start treating these patients. Of course, as has been discussed earlier, we need to determine the cause also if it is not obvious in history. Now let's do some exercise. Let's think your input. I will expose these one by one, and you will have some time to ponder and you come up with the correct answer. So if we're dealing with a case of iron deficiency anemia, what would be abnormality in these parameters? HB, hematocrit, of course, this is quite obvious, would be low, and MCV, which is mean corpuscular volume, MCH, which is mean corpuscular hemoglobin, and MCHC, which is mean corpuscular hemoglobin concentration. These are collectively called red cell indices. They will be reduced, because if this and this is reduced, only then we will call it hypochromic microcytic. So these anemias are hypochromic, means that amount of hemoglobin in one cell is reduced, and microcytic means that the cell size is also small, and these indices will be reduced. This is actually the hallmark of iron deficiency anemia. Then ferritin in a typical case would be reduced. Serum iron will also be reduced. Total iron binding capacity will be increased, and if we go for bone marrow, the iron will be absent. And retic count may be non-specific, may be normal, or may be low because there is reduced bone marrow activity. Reticulocyte count actually indicates the bone marrow activity. The reticulocytes are actually young red blood cells, only one day old, so they would indicate the activity of bone marrow. Since iron is deficient, bone marrow is not reactive, so I think retic count may be low. It would certainly not be high. So this is the total picture of iron deficiency anemia. The treatment of iron deficiency anemia is important. First of all, it is important to identify the underlying cause. If that is possible, I think that is absolutely great. And not only that, we have to address the underlying cause, because otherwise there will be continuous blood loss and iron replacement will also not work, because the underlying cause may be actually potentially serious. There may be like a tumor in the stomach or in the colon, so that needs to be treated. So we have to work both ways to find out the underlying cause and treat it, and we also have to replace iron. It is very, I think, common practice to give blood transfusion. In iron deficiency anemia, I think blood transfusion is hardly ever needed. Blood transfusion is actually indicated only in those patients who have critical drop in HB, and they are symptomatic and they are hemodynamically stable and cause is not exactly obvious. So in that situation, primarily to treat their hypovolemic state and critical anemia, blood transfusion may be needed. Otherwise, in iron deficiency anemia, we need to replace the iron, and blood transfusion should be avoided if possible, because blood transfusion has got many hazards. And oral iron is the standard treatment. There are various forms, and ferrous sulfate is perhaps the cheapest and the best. Some people, they have the problem of gastric irritation. Iron can sometimes disturb your stomach. It may cause dyspepsia, it may cause stomach pain, it may cause bloating, it may cause gases, it may cause constipation. So various types of GI problems are possible with oral iron. Although iron is best absorbed if taken on empty stomach, but because of this GI side effects, typically we prescribe iron with meal. So less amount will be absorbed, but it will not cause stomach irritation. And iron is also best absorbed if given with ascorbic acid. So many of the iron preparations, they also have some ascorbic acid, which is vitamin C, or patient can take vitamin C separately or can take some citrus juice with this iron tablets. Various iron tablets are available. They say that this one is stomach friendly and this one is stomach friendly. They have actually bound iron with certain other substances to make it less gastric irritant. But generally speaking, those preparations which are less irritant, they also have lesser amount of iron in it. So I think normally we should try this basic cheap source of iron, which type of iron, ferrous sulfate. One tablet per day may be sufficient for majority, but sometimes we have to give twice a day also. As I said earlier, best is empty stomach to have maximum absorption, but safest is to give it with meal. So patient can be asked to take one pill a day with meal. You also have to explain to the patient that iron is going to darken their stool. Otherwise, in the history, you would ask if there is any dark stool, and once you prescribe iron, patient will start passing dark stool and will be worried why this has happened. So I think we need to explain to the patient that this is the black stool. In this case would be the sign of iron intake. Parenteral iron is available. Some way back it used to be a common practice to give parenteral iron intramuscular injection. Intramuscular injection is not available anymore. Intravenous iron is available. There are two main forms available. One is 100 milligram, the other is 500 milligram. Parenteral iron can cause hypersensitivity reaction. So parenteral iron is usually recommended only if there is patient cannot take oral iron. If you replace iron orally or parenterally, it would probably take the same time for the hemopoiesis, because rate limiting factor is our bone marrow. If you replace the complete amount of the total deficient iron over 2 days, that does not mean that that patient's hemoglobin will be normalized in a week or so. It will still take two or 3 months because hemopoiesis is slow. So the degree of anemia does not favor parenteral iron. Only if somebody is unable to tolerate oral iron, only then I think we should give parenteral iron. Another situation is that when the requirement for iron is so much, for example, you are giving bone marrow stimulating factors, erythropoietin, or I think in that situation also, when there is massive anemia, very severe anemia, and you're stimulating bone marrow, maybe oral iron will not be able to meet the requirement. That is another case for parenteral iron. Some people, they just can't take oral. They don't like the concept of taking daily medication. They may also be offered parenteral iron, but parenteral iron has the problem of hypersensitivity reaction. The newer agents, they are claimed to be at least less likely to cause these reactions, and I've seen recently that these drugs actually, they are very safe. So you can actually calculate the total amount of iron and give it intravenously, and this must be given in the hospital setting in case hypersensitive reaction occurs, so that can be managed better in the hospital setting. Good nutrition, and good nutrition means, from the iron perspective, only iron is present in good quality and good quantity in meat, in red meat. Also some in fish, also some in poultry, but red meat, and especially the organ meat, that is very rich in iron. But of course that is perhaps not, I think, the substitute of ferrous sulfate, because this is a cheap source. I would actually advise both iron tablets and also good nutrition in the form of red meat. So that was iron deficiency anemia. Very briefly, there's another picture which on the CBC might look like iron deficiency anemia, but that may be refractory to iron because many patients are just treated with iron without investigation, and if they do not respond, do consider this condition sideroblastic anemia. Some basic facts about sideroblastic anemia. The picture of CBC would be hypochromic microcytic, exactly the type we see in iron deficiency anemia, but iron is actually in excess. Why? Because there is some metabolic problem. The iron is present in the body, but it cannot be used for the synthesis of hemoglobin. That concept is very complex and we do not understand it fully, but iron is not deficient, it is only not used for the hemoglobin synthesis. The picture will be hypochromic microcytic as if there is iron deficiency, but actually iron is not deficient. Now, excessive iron in the bone marrow in the form of ring sideroblasts. This would be a situation to go for bone marrow. Iron is present and in the form of ring sideroblasts. These sideroblasts are some RBC precursors or maybe macrophages which have a lot of iron in it in the form of ring. So that would indicate that iron is actually in excess although patient has anemia. It may be hereditary or acquired. If it is acquired, it would be a part of myelodysplastic syndrome. Both are potentially serious causes, and it is, I think, much more serious than simple iron deficiency anemia. If you go for the investigation, everything will be the same as we see in iron deficiency anemia, but you need to concentrate on these portions. Ferritin and iron level would be high because there is iron in the body, it is not being used. They would be high, and bone marrow will show ring sideroblasts. So in this case, of course, it would make no sense to prescribe iron. In fact, you will probably have to remove some iron from the body. Treatment of sideroblastic anemia, iron is contraindicated. Patient should not be given any iron containing preparation. There are many multivitamins which have some quantity of iron. Patient should not take that also, and patient should also avoid iron rich diet like red meat. Then in some cases, if ferritin is very high, then iron chelating therapy, which is beyond the scope of the selective, but iron chelating therapy may be needed to remove extra iron in the body. And prognosis is generally poor because the prognosis is that of underlying disease. It could be hereditary or myelodysplastic syndrome. Both have inherently poor prognosis, so it has much poor prognosis than simple iron deficiency anemia. That is all. This was a brief account of iron deficiency anemia and a picture very similar sideroblastic anemia. I hope I was able to give you some useful information which will help you to make a diagnosis and to treat your patient. Iron studies may be needed in some cases, but not in all. And remember, if you have diagnosed iron deficiency anemia, do consider the cause of iron deficiency. If that is obvious in the history, no further tests. Otherwise, you have to look into the GIT, especially if the patient is elderly, and especially if there are some other signs of suggestive of something serious like weight loss. So you need to have a deeper probe into the possible cause. So this was Professor Aziz-ur-Rehman from Medurstand. I look forward to see you in my next video on aplastic anemia. Thank you very much.